Okay, what's up guys? Welcome back. This is going to be part 2 of the pulmonary practice questions for Pance studying. We left off at Bordetella pertussis, so now we'll continue on with the next question. So a 3-year-old comes in with 3 days of rhinitis and a low-grade fever and a stuffy nose. His mom says he's now been developing some wheezing, nasal flaring, and cough. She admits that she smokes in the house and the baby was also a preemie, and she states that she did not breastfeed and also lives in a crowded home. What is the diagnosis? So many risk factors here. So not breastfeeding, living in a crowded home, baby was a preemie. They also had some URI symptoms before having this wheezing, nasal flaring, and cough that they're having now. What is this diagnosis? What is the most common cause of this condition? So what is the most common cause of this condition? What is the best indicator of prognosis as we monitor them? What would have been helpful to start as a medication in this baby, knowing he was a preemie in the first place? So what could they have started? So this is going to be acute bronchiolitis. RSV is the most common cause, respiratory syncytial virus. We can monitor their pulse ox to see how well they're actually doing. And the medication that would have been good would be Synagis. So that's pembrolizumab. It's given under 1 year old for preemies, and especially if they have a chronic disease of the heart or lung. And also it's important to know, I've seen a couple questions like what's the best next step for these symptoms that the patient's having since it is a viral infection, RSV. You want to do nasal suctioning. So nasal suctioning is a good first step, and hand washing is preventative, importantly to know. Okay, so next question, quite a few ones for this. A 7-month-old unvaccinated male comes in with dysphagia, drooling, and distress. What's on the top of your differential? So they have this triad of dysphagia, drooling, and distress in a 7-month-old, and they're unvaccinated. What is the cause of this most commonly? So what is the most common cause? What else might you find on physical exam? After making the preliminary diagnosis, what is an imperative next step in the management for this patient? What is classically seen on neck radiographs? So what is classically seen on neck radiographs? And lastly, what is the medical treatment? So quite a few important questions. We have to know a lot about this condition. Again, 7-month-old unvaccinated, 3Ds, dysphagia, drooling, and distress. So this is, of course, acute epiglottitis. If they're unvaccinated, then the most common cause is Haemophilus influenza type B. If they are vaccinated, now we want to be suspecting strep species. But I would say if they ask you what the most common cause is and they don't tell you if they're unvaccinated or not, I would go with Hib. The 3Ds, again, dysphagia, drooling, and distress. Tripod positioning, sitting leaning forward with the elbows of their lap. That's called that tripoding position. They may also have a hot potato voice, which we could potentially see in paratonsillar abscess as well. And also inspiratory stridor too. The first step, the most important, is to secure the airway. We can do a laryngoscopy and see a cherry red epiglottis while securing the airway. So this is done at the same time. And of course, the OR is the best setting for this. On neck radiographs, we can see a thumbprint sign, important to know. And also ceftriaxone is the treatment for Haemophilus influenza B. Okay, next one. A patient comes in the winter with a harsh barking cough and a hoarse voice. They're 3 years old. What do you suspect? Again, a harsh barking cough in the winter, 3 years old. What do you want to be suspecting? What is the most common cause of this? What is the classic sign on radiographs that can be seen? And how do we manage it if it's mild, moderate, or severe? So with this, we can do a specific score, and we can see if they're mild, moderate, or severe, and that will dictate our treatment for this condition. So this is, of course, Croup, laryngotracheobronchitis, technically. Croup, most common cause is parainfluenza type 1. We'll see the steeple sign on radiographs, the steeple sign. Classically, of course, that seal-like barking cough and inspiratory stridor. For mild, if they're having no stridor at rest, no distress, we can just do dexamethasone and supportive like cool mist, cool air. If it's more moderate, we can do dexamethasone and nebulized epi. Observe them for a couple hours and then they can go home. If it is severe, we want to do again the dexamethasone, the nebulized epinephrine, and also admit them. And if it is severe, then we're going to be seeing stridor at rest with retractions. So if we see that they're a little bit unstable, starting to have a lower pulse ox, and they're having stridor at rest with retractions, that's indicative of severe croup. Again, dexamethasone, nebulize epi, and admit them. Next question. What condition has dullness to percussion and a decreased fremitus? So it's important to know the physical exam findings. They might give you a general respiratory condition and give you physical exam findings and expect you to know what it is. So this patient here has dullness to percussion and decreased fremitus. Decreased fremitus, what is that? What condition has hyperresonance to percussion and decreased fremitus? And what condition has dullness to percussion and increased fremitus? So increased fremitus, that's important to know. So the first one is going to be pleural effusion, dullness to percussion, and a decreased fremitus. The second one is going to be a pneumothorax, which is hyperresonance to percussion and a decreased fremitus. They're air-filled lungs after all, and obstructive lung disease. And the third one, again, dullness to percussion and increased fremitus. That's classically pneumonia. So it's important to know the increased fremitus in pneumonia. And increased fluid in the lungs leads to increased sound as fremitus vibrates through the fluid. And it's also dull because it's consolidated. So the most important one to know how to say is pneumonia. And again, that's that increased fremitus because the fluid is actually in the lungs, whereas pleural effusion has decreased fremitus because there's not actually fluid in the lungs, it's more so in the pleura itself. Okay, next we're going to do guess the type of pneumonia. So it's really important to know a lot of high-yield information of the specific types of pneumonia, the atypicals, the typicals, and a lot of specific buzzwords that they might give you in the vignette that will clue you off to specific types of pneumonia. So we'll go through a bunch here and see if you know, just based on a couple words, what type of pneumonia it is. So first one, which one is associated with cold agglutinins? So cold agglutinins, which one is associated with that? Which one can be diagnosed by a urine antigen test? So a urine antigen test, which one can you diagnose? Which one is associated with purple-colored current jelly sputum? Purple-colored current jelly sputum. Which one is hospital-acquired or superimposed after a viral infection? Which one is the most common type of pneumonia overall? Which one is common in young and healthy patients with a dry cough? So young and healthy patient with a dry cough, what would that be more likely to be? Which one is a sudden onset of chills and rigors? Classically, sudden onset chills and rigors. Which one is common in COPD? Which one has blood-tinged rusty sputum? Blood-tinged rusty sputum. Which one is common in chronic alcoholism? Which one is associated with bullous meningitis? Bullous meningitis. Which one is an outbreak from a contaminated water source? So importantly, contaminated water source. Which one is mostly caused by anaerobes? Which one has hyponatremia, diarrhea, and increased LFTs? Hyponatremia, diarrhea, and increased LFTs. What are the three common atypical causes of pneumonia? Three common atypical causes of pneumonia. Which one's associated with erythema multiforme as well? Important to know that one. Which one's associated with erythema multiforme? Okay, now the answers. So first one, cold agglutinins, that's associated with mycoplasma pneumonia. So don't forget that, cold agglutinins, mycoplasma pneumonia. Urine antigen, we diagnose Legionella with urine antigen. So you can just think of Legionella as associated with water antigen for Legionella. Purple-colored current jelly sputum, that's Klebsiella. Purple-colored current jelly sputum, Klebsiella. Hospital-acquired or superimposed after a viral infection, that's going to be Staph aureus. The most common overall is going to be strep pneumoniae, of course. Which one's common in young and healthy with a dry cough? Also mycoplasma. Again, healthy with a dry cough, young patient, mycoplasma. Sudden onset of chills and rigors, strep pneumo, characteristically. Common in COPD, that's H-flu. We already mentioned that. Haemophilus influenza in COPD. Blood-tinged rusty sputum, that's strep pneumoniae. Chronic alcoholism, Klebsiella. Associated with bullous meningitis, that's going to be mycoplasma. Outbreaks from a contaminated water source, again, thinking water, we want to think of Legionella. Most commonly caused by anaerobes, that's going to be aspiration pneumonia. So most commonly caused by anaerobes, that's going to be aspiration pneumonia. Hyponatremia, diarrhea, and increased LFTs, that's going to be Legionella. So Legionella, and also if they have neurosymptoms from that hyponatremia, you could be thinking of Legionella. They might just give you some neurosymptoms and expect you to know hyponatremia associated with Legionella. Three most common atypical causes, I remember that is MCL, Mycoplasma, Chlamydia, and Legionella. Associated with erythema multiforme, Mycoplasma, as you remember that. Associated with erythema multiforme, Mycoplasma. Okay, next one. A patient from a nursing home is brought to the hospital with symptoms of pneumonia that started 24 hours ago. Is she community acquired or hospital acquired? What does the CURB 65 stand for, and tell us? So she has healthcare associated pneumonia. Since it's a nursing home, is not considered a community acquired, even though it's been under 48 hours. So I got this question wrong, and it's healthcare associated as opposed to hospital acquired. But we always have to remember that nursing home is still considered healthcare associated or hospital acquired. Confusion, uremia, and respirations over 30, and blood pressure, hypotensive, and age over 65. So that's the CURB 65. Again, confusion, uremia, and respirations over 30, blood pressure under 90, under 60, and an age over 65. If we have two of them, we need to admit them. It helps to tell us if to admit in pneumonia or not. That's the CURB 65. What is the treatment for community-acquired outpatient pneumonia? Community-acquired outpatient pneumonia, what's the treatment? How about community-acquired pneumonia inpatient? How about hospital-acquired pneumonia? So the first one, community-acquired outpatient, is going to be macrolide or doxy. Or if they have immunocompromised or comorbid condition, then we can just use a solo fluoroquinolone. And that's for outpatient community-acquired. So these treatments are a little bit tough to get, but after some familiarity, macrolide or doxy for outpatient community-acquired, immunocompromised or comorbid, then fluoroquinolone only. Community-acquired inpatient is going to be a beta-lactam plus either a macrolide or doxy. So you want to have two treatments initially for this. Or if they're comorbid, then you can have a fluoroquinolone only as well. But so a beta-lactam plus either a macrolide or doxy. So you want two medications here. For hospital-acquired, you want to do an anti-pseudomonal beta-lactam like piperacillin tazobactam, ceftazidime, and cefepime or cefepime, plus an aminoglycoside or fluoroquinolone. So you can do an anti-pseudomonal beta-lactam, one of these, plus an aminoglycoside or fluoroquinolone. So again, you want two treatments for this one and two treatments for that inpatient community acquired as well. Unless they have comorbid conditions, then you can use that fluoroquinolone only. You notice a semi-conscious homeless patient with very poor dentition coming in with a foul-smelling sputum with a cough and a fever. His pulse ox is 89 and his right lobe has increased fremitus. What is the diagnosis? What is the most common cause generally in this condition? So again, right lobe, increased fremitus, foul-smelling sputum, semi-conscious homeless patient with poor dentition, pulse ox is low. What's the treatment in this patient? So this is going to be aspiration pneumonia. It's caused by anaerobes, and the treatment we can do is Unison, which is ampicillin sulbactam. Augmentin can also be used for aspiration pneumonia as well. And again, aspiration pneumonia, foul-smelling sputum you want to be thinking of. Also semi-conscious homeless patient with poor dentition. So it's typically those oral anaerobic flora that can get into the lungs there. Okay, you're working in a rural practice along the Mississippi River when a male comes in with some mild flu-like symptoms. On history, he notes he has been exploring caves. What diagnosis are you considering based off the risk factors alone? So, two biggest things, he's been exploring caves, he's in the Mississippi River, and he has mild flu-like symptoms. Also, how should we treat them? And how does this transmit? How does this condition transmit? So this is histoplasmosis, Histoplasma capsulatum. It's a dimorphic yeast. How they get it is an inhalation of soil containing bird or bat droppings in the Mississippi and Ohio River Valley, and also spelunkers, which is people who explore caves, is a risk factor. How do we diagnose? Urine or sputum PCR. And if mild, they don't need treatment. If it's moderate, itraconazole, or if it's severe, amphotericin B. So mild, no really treatment necessary. Our immune system will take care of it. If it's moderate, you can do itraconazole, or if it's severe, amphotericin B. Next patient comes in asking what pneumococcal vaccine she needs today. She's a 67-year-old, otherwise healthy female, and she states she has never had any vaccinations before. Never had any vaccinations before, 67 years old. And another question about vaccines, a patient has had the PPSV 23 when she was 58, and now she's turning 65 and wonders if she needs to have it again because she read that people need it after 65. So what would you tell her in this situation? She again got it at 58, now she's turning 65, the PPSV 23. What should she do? So the first one, she was never vaccinated, so we want to start with the PCV 13, and then 8 weeks later we can give the PPSV 23. So we said she is 67, so she's past 65, and if they never had a vaccine up until then, still start with that PCV 13, and then 8 weeks later do that PPSV 23. Second patient here, she was 58 when she got it, the PPSV 23, and now she's turning 65. We don't need to give it to her at 65. We can give it to her at 68 because she got it at 58. So that would be 10 years after. And that's if it's under 10 years prior to 65. So if it is under 10 years prior to 65, she was at 58, then she should get it at that 10-year mark. Again, the PPSV 23. Okay, next one. A patient with HIV comes in with an O2 SAT of 89 and a PaO2 of 65. You know shortness of breath. What is at the top of your differential? So we should be knowing somebody with respiratory condition and HIV, shortness of breath, what's at the top of your differential? What might we see on chest x-ray classically? How about a common lab finding in this patient? And what is the treatment for this specific patient given the labs in this vignette? So what is the best treatment for this patient? And especially in regards to the labs here. So the O2 SAT of 89 and the PaO2 of 65. When do we prophylax? So this is PCP, pneumocystis pneumonia. Classically on x-ray, we'll see bilateral, diffuse, symmetric, finely granular opacities and a reticular interstitial airspace disease. So again, bilateral, diffuse, symmetric, finely granular opacities, reticular interstitial airspace disease. On labs, we'll see an increased LDH over 200. And remember, because the CD4 is below 200. So that's how I remember that the LDH should be over 200 in PCP, is because the CD4 should be under 200 if we're going to be getting this condition. So, of course, HIV risk factor, especially CD4 under 200. What is the treatment? Of course, we need to do Bactrim, trimethoprim sulfamethoxazole in patients with below a PaO2 of 70. We should also add prednisone. So if they're hypoxic, you want to add prednisone to the Bactrim you're already giving them. If they're not hypoxic, they have no symptoms, and they have a PaO2 of higher than 70, then we can just give them that Bactrim for 21 days. But if they do have a PaO2 under 70, like the patient in the vignette who had a 65 PaO2, then we want to add prednisone to this condition. Second line is dapsone for PCP, and prophylaxis is an HIV with CD4 under 200. This is the most common opportunistic infection in HIV. Next one. A 29-year-old prison inmate comes in with a cough and hemoptysis. He has also developed a fever over the past couple days. What are you thinking? So again, prison inmate, cough and hemoptysis, fever. What do you think it is? What three things are needed to define this as a latent infection? So it kind of gives it away, but what three things are needed to define this as a latent infection? Name at least three extrapulmonary findings in this condition. So there's quite a few. Name at least three. And some more questions about this condition. A millet seed appearance is seen on chest x-ray. What does this mean? What does this represent? So a millet seed appearance on chest x-ray, what does this represent? What subset of this condition could you see a caseating granuloma in the upper lobe? So when would you actually see upper lobe involvement, and when would you see lower lobe involvement in this condition? So when upper, when lower lobe involvement? So of course this is going to be TB, tuberculosis. For latent, you should have the three things that you need are a positive PPD to actually prove that they have it, and a positive PPD can occur 2 to 4 weeks after the initial infection. You have to have a negative chest x-ray and also no symptoms. So they have to be asymptomatic, a negative chest x-ray, but they still have a positive PPD, then you can call that latent TB. What are some of the extrapulmonary manifestations? One, of course, that we need to know is scrofula, and that's also cervical lymphadenopathy. So pretty severe manifestations if you look up a Google image of that. Scrofula, cervical lymphadenopathy. Also, Pott's disease is TB of the spine. They could also have TB pericarditis. They could have TB meningitis. And that millet seed pattern that we were wondering about, miliary TB. That's called miliary TB, and that's diffusely throughout the lungs. The upper lobe is secondary reactivation. So you can think about that as secondary reactivation because that TB is looking for the oxygen, so it goes to the upper lobe. Lower lobe is primary. Lower lobe is primary. How do we manage active TB? What drug leads to an orange-colored secretion? So a lot of questions, they might just give you the side effect of the drug, and they really want you to know the side effects of these drugs. So again, how do we manage active TB? What regimen are we going to use? What drug leads to this orange-colored secretions? How about peripheral neuropathy and hepatitis, which can be allayed by what? So what medication do we use to decrease the risk of this peripheral neuropathy occurring in this medication? Which one can cause gout and liver disease? Which one causes optic neuritis? And which one is oto and nephrotoxic? So we should know the main side effect, at least one of these main side effects for each of these medications. So active TB gets the RIPE or RIPS treatment. S is for streptomycin, which can be used instead of ethambutol or ethambutol. And rifampin, isoniazid, pyrazinamide, and ethambutol are the RIPE treatment. Rifampin is the first one. Then isoniazid for 6 months. So rifampin and isoniazid should be used for the complete 6 months, but pyrazinamide and ethambutol are only 2 months each. So after the first 2 months, you can discontinue pyrazinamide and ethambutol for a primary TB, but you still want to continue the rifampin and isoniazid after that. So rifampin is going to be the one with those orange-colored secretions we want to be thinking about, and also thrombocytopenia. Isoniazid, is the peripheral neuropathy, and which can be allayed by B6, decrease the risk of having the peripheral neuropathy with B6. We also think about increased anion gap metabolic acidosis with isoniazid. It's in our mud pilers mnemonic too. Also cytochrome P450 with isoniazid as well. But don't forget isoniazid and that B6 in the peripheral neuropathy. Pyrazinamide for gout and liver disease, we want to be cautious with, and also pregnancy. Shouldn't be using pyrazinamide in the first trimester. Ethambutol is ithambutol, that's how I remember it. And this is optic neuritis and eye problems. And streptomycin, that's an aminoglycoside after all, so we would be thinking ototoxic and nephrotoxic for streptomycin. What one medication is best for latent TB treatment? So if we just had to use one medication for latent TB, what would it be, and how long would we treat it for? What are we looking for after administering a PPD? So what are we specifically looking for? How long do we wait after administering a purified protein derivative test for TB? Next best step after seeing a positive PPD. So we get it back and it's positive based on what we are looking for. What will we do next in that case? So the best medication for that latent TB treatment, that's going to be the isoniazid with B6, of course, pyridoxine, for 9 months. So we can just do that solo drug, isoniazid, for 9 months. It inhibits the mycolic acid synthesis, isoniazid does, so that could really go against the tuberculosis and kill it. So we want to do that for 9 months, isoniazid. What are we looking for with a PPD? We want to be looking for after 48 to 72 hours, 2 to 3 days. We want to be looking for not the erythema, but the transverse induration. So they can ask you that. Transverse induration is what we're looking for. And of course, after seeing a positive PPD, we want to get a chest x-ray. And remember, what qualifies latent TB is a negative chest x-ray, no symptoms, but a positive PPD. Okay, next question. What is the deal with the BCG vaccine? Does it affect our testing here in the US? So this is given in other countries for tuberculosis, the BCG vaccine. What does it have to do with us if somebody has it? How is that going to alter what we see on our tests and our treatment? Next one, a patient comes in that has had a recent kidney transplant. So recent kidney transplant. You do a PPD. What reaction size of induration would be a positive test? Next one, a person working in an infectious disease outpatient clinic but has not had any contact with anybody with TB. What is their positive induration? And lastly, 2 more questions. A 34-year-old otherwise healthy male with no risk factors, what induration do they need to show? And what is the gold standard test for TB? So what's the gold standard? And it's important to know the size of the induration for each of these, as what the risk factors are. These are like very commonly asked questions. So the BCG, the only thing that we really need to know is that it's going to show a false positive for the PPD. That's it. It has no impact on the recommendations in the US for the treatment or screening of latent TB. So only needs to know that it's going to show a false positive. So the person with a kidney transplant, that's going to be an over 5 millimeter induration. They're probably on immunosuppression meds since they had a recent transplant, so they're immunocompromised, of course. So that's going to be over 5. Anybody who's immunocompromised, exposure to TB, etc., that's an over 5 is going to be considered positive for that PPD. This person, the second one in the outpatient clinic, that's going to be a healthcare worker. So they're going to be over 10 millimeters as a positive induration. And over 15 millimeters is the general population, otherwise healthy with no risk factors. The gold standard test for TB is the IGRA, interferon gamma release assay. That's the gold standard, and that's a blood test. Next question. What is the most common cause of a solitary pulmonary nodule? Most common cause of a solitary pulmonary nodule. What are some characteristics of an increased risk for cancer if you find a nodule? So there's certain characteristics that you'll see that are increasing the risk for cancer from a solitary pulmonary nodule. So after the initial chest x-ray, what is the next best imaging modality to further assess this nodule? So the most common cause is an infectious granuloma. Infectious granuloma, most common cause of solitary pulmonary nodule. Spiculated nodule is a risk factor for cancer if it's larger than 20 millimeters or 2 centimeters, if it has irregular borders, if it has asymmetric calcifications, if it has upper lobe involvement, importantly, if the patient's over 40 years old and if they're a smoker. And the next step that we do after a chest x-ray and we have suspicious findings, we want to get a chest CT to further assess it. Okay, so next one, patient comes in with diarrhea, sweating, and flushing. On physical exam, you note tachycardia and some shortness of breath. Lab shown increased urine 5-HIAA. What is the diagnosis? So again, diarrhea, importantly, sweating and flushing, and also some shortness of breath. Urine 5-HIAA. What is that? What will we see on bronchoscopy if we take a look, classically? And what are these symptoms due to, exactly? So what exactly, not the diagnosis, but what are the symptoms due to? So this is going to be a bronchial carcinoid tumor. It's most common in the GI tract, but it's also in the lungs. So again, bronchial carcinoid tumor. We talked about that in the GI system. On bronchoscopy, it'll show a pink to purple, well-vascularized, centrally located tumor. So again, pink to purple, well-vascularized, centrally located. What are these symptoms due to? Histamine release, mainly. Flushing, tachycardia, and bronchoconstriction. That's going to be due to the histamine. And of course, the diarrhea is going to be due to that serotonin release. We said he had a positive urine 5-HIAA, and that's the metabolic breakdown product of serotonin. So that kind of gives it away that this is a carcinoid tumor. Next one, what is the most common cause of cancer-related death in the U.S.? Most common cause of cancer-related death in the U.S., but not most common cause of cancer. A patient comes in who is 61 years old. He states he smoked for most of his life, but did quit 4 years ago. So he's 61, smoked for, let's say, over 30 years, over 30 pack years, but he did quit 4 years ago. He is wondering about annual screening. What would you recommend? He already quit 4 years ago. So the answer is this: lung cancer, most common cause of cancer, death. You would recommend an annual low-dose CT scan in those 55 to 80 that have at least 30 pack years of smoking and currently smoke or quit within the last 15 years, and they're asymptomatic. So they have to be asymptomatic. And he quit 4 years ago, but he still had over 30 years of 30 pack years, and it's within the past 15 years. Don't forget that. So past 15 years, even if they quit 12 years ago, past 15 years, 55 to 80 annual low-dose CT scan. So next one's going to be name the type of cancer. It's going to be either adenocarcinoma, small cell lung cancer, or squamous cell. So they often give you some symptoms, the location, or other attributes of these cancers, and you have to know exactly which one it is, and they'll want you to associate those keywords, those buzzwords, with that specific cancer. So we'll go through a long list of many different attributes of these different ones and see if you can think about it in your mind which one it is. So we'll start off here. Superior vena cava syndrome. Which one of these, adeno, small cell, squamous, is associated with superior vena cava syndrome? Which one is associated with hypercalcemia? Important to know, hypercalcemia. Which one is peripherally located? Which one is chemotherapy as the treatment? Which one has mucin production or gland formation? Again, mucin production or gland formation. Which one has classically cavitary lesions? Which one is associated with SIADH, syndrome of inappropriate ADH? Which one has Pancoast syndrome associated with it? Pancoast syndrome. Which one is also called oat cell? Which one has a lipidic pattern sometimes? Lipidic pattern. Which one is more common in non-smokers? Which one is more common in non-smokers? Which one has early metastasis? Lambert-Eaton myasthenic syndrome is associated with which type? And which is the most common overall? So the first one, superior vena cava syndrome, that's going to be small cell lung cancer. So superior vena cava syndrome, again, one of those paraneoplastic phenomenon, small cell lung cancer. Hypercalcemia, that's importantly squamous cell lung cancer. So it's part of that CCCP, hypercalcemia, squamous cell carcinoma. Peripherally located, that's going to be adenocarcinoma, as the other two are central, so small cell is central and so is squamous. Chemotherapy as treatment, small cell lung cancer, adeno is surgery. Right, so chemotherapy, it's typically metastasized, so you need to do chemo, small cell lung cancer is. Mucin production, gland formation, that's adenocarcinoma, classically. Cavitary lesions, also part of that CCCP, squamous cell carcinoma, so cavitary lesions, centrally located, hypercalcemia, and Pancoast tumor. So CCCP for squamous, cavitary lesions. SIADH, again, one of those paraneoplastic phenomena, that's small cell lung cancer. Pancoast syndrome, like we said, squamous. Oat cell is also known as small cell lung cancer. Lipidic pattern, importantly, is adenocarcinoma. Don't forget that lipidic pattern, adenocarcinoma. More common in non-smokers, adenocarcinoma. And adenocarcinoma is the most common overall and is more common in smokers too. So more common in non-smokers and more common in smokers, adenocarcinoma. Early metastasis, small cell lung cancer. That's why we need to do chemo for this. Lambert-Eaton myasthenic syndrome, another paraneoplastic phenomena, small cell lung cancer. Okay, next question, a vignette. A 65-year-old with 39 pack years of smoking presents complaining of weakness in the morning. He states that it does get better throughout the day. It does get better. He also notes postural hypotension and a dry mouth. What is the diagnosis? How do we treat this condition? And what is the pathophysiology of this condition? This is Lambert-Eaton myasthenic syndrome. It's better with muscle use, as seen on the EMG. Electromyography. Treat the underlying malignancy is how we do it. Small cell lung cancer is associated with it. Medically, we can do pyridostigmine, which is acetylcholinesterase inhibitor, so it keeps that acetylcholine in the synapse by inhibiting what would normally take it out of the synapse, the acetylcholinesterase. Antibodies versus calcium that are voltage gated, which prevent ACH release into the synapse. So it's similar to myasthenia gravis, but it gets better, whereas myasthenia gravis gets worse over the course of the day. And this is because that over time, we're able to keep more acetylcholine in the synapse as it's antibodies against the calcium channels that would typically release the acetylcholine into the synapse. And of course, acetylcholine, why we're having that weakness, postural hypotension, and the dry mouth is due to the lack of ACH at the neuromuscular junction. So therefore, we can't squeeze the saliva glands. We have a dry mouth, and we need to contract the vessels. So we're going to have hypotension. If the vessels can't contract, we're going to have pooling of the blood.